Or will I just use the mouse?
You can use the mouse.
Okay, that's fine. Okay. That's fine.
Yep.
Thank you very much.
When you lose, it will show up here.
And I might, right? So the mic is on.
Mic is on. Yeah.
Are you recording or?
It is recording.
Are you recording audio and video or okay.
So the people in Brooklyn can hear it. It would be great if possible. Oh yeah, I can have that over. Yeah. Thank you, Mom.
That's always great from a
Review and
Good morning, everybody, and welcome to Grand Rounds, where MIS Bariatrics is hosting it today. And the reason the chief of MIS asked me to do the introductions is that the speaker, like me, is an Antipodean a long way from where he came from. It says Dublin, but he's from South Africa. And so they asked me to give the introduction because to his great delight, South Africa is in the final of the World Cup rugby contest, which is next weekend, and he will be insufferable until the game's over. But we're so thrilled to have Carl here. He's truly a world leader in research into the causes and potential ways of managing obesity. As I said, he's come a long way from Pretoria, and then he went to London, and now he's in Dublin. But he's recognized as a world leader in this field, and let's be honest, this is a very important field because of the effect it has on world health and finance for countries. So it's with great pleasure that I introduce Carel le Roux to give his talk today.
Well, thank you so much for this opportunity to sort of share some of our ideas and thoughts with you. So I work as a clinician scientist. I see patients every day, and I also treat rats in the laboratory and run a research lab. And our sort of thinking has really been about understanding the problem of obesity. But I've been given this great title about the biggest loser, truth or fantasy. So I'll remind you, this is the famous Hans Christian Andersen tale. And this tale is of the tailors that came to the emperor and said to the emperor, actually, you know, we can make you beautiful clothes, but only intelligent people can see your clothes. And of course, what happened is the emperor wore these beautiful robes. Of course, he couldn't see, but he didn't want to tell people that he wasn't intelligent enough to see this. And as he walked down the road, all the populace were absolutely enamored with this. They were saying, what beautiful clothes this were. They haven't seen anything like that. Except this little boy in the background over here who put his hand up and said, is the emperor wearing clothes? And so I would like you for the next half an hour to be that little boy, to put your hands up and say, you know, is the emperor really wearing new clothes? Because we have been told things by these tailors about how people should lose weight. And I think it's time that we actually look back at the science and consider where we need to go. These are my conflicts of interest, and I'm an internal medicine doctor, but I work with lots of different companies, pharmaceutical companies, nutrition companies, as well as surgical companies, because we do not think obesity is one disease. If we sat here in the 1950s and we talked about cancer, we would all be trying to find the cure for cancer, thinking it's one thing. And that's a little bit where we are right now, thinking that obesity is one disease and therefore there needs to be one treatment. But in fact, what we are seeing is a heterogeneous bunch of sets of diseases that will need specific treatments. And therefore, I think we need more treatments. We need more diet approaches, more exercise, more medication, and more surgery. And we really need to understand how we can use these treatments together. But here is the challenge. So at the moment, if you go to a really nice dinner party and you sit with some smart people around the table, they will tell you the treatment for obesity is to eat less and to move more. Right? And we even go to big TV programs such as The Biggest Loser, and that is what they show you. They show that if you can only get people to be better citizens, right? If they can only be better individuals by moving more, then it is going to help and it's going to cure this problem. And of course, if you ask people today, which we have done in multiple surveys in the US, in Canada, and around the world, what is the number one thing that stops you from losing weight? The response from patients is lack of exercise. If you ask healthcare professionals, smart family practitioners, smart hospital specialists, what is the one thing that stops your patients from losing weight? The answer comes back as lack of exercise. Now, the science is completely disconnected from this, but it is easier for me to tell you that the earth is flat than to explain to you that exercise is not going to be the long-term solution when it comes to the treatment of obesity. But if you apply this model where you make people eat less and move more, what you will find is this result. This is a lady who was able to do just that, eat less and move more, was able to go from this state to this state, and then goes to this state. Right? This is normal physiology. If this does not happen, then we become really interested in the minority of people that are able to lose weight and maintain the weight loss in the long term. Because weight is regulated in the same way as your body temperature is regulated. So I'm going to ask each one of you in the audience here just to sit there for a moment and motivate yourself to increase your body temperature by 0.5 degree. Okay? You guys are smart enough, to know what body temperature is, and you're smart enough to actually understand the instruction, but none of you have the connections between your cortical areas and your subcortical areas of the brain to change your body temperature as you're sitting there. And what happens when we actually ask people to move more and eat less, what happens is their subcortical areas of the brain will allow them to become more hungry and less satisfied. And you ask anybody that's ever been on a diet, and they will tell you they've never been as obsessed with food as when they were on a diet. That is normal physiology. So what we need to do is we need to understand physiology so that we can help people in the long term lose and maintain weight loss. So let's go back to the Second World War. And here I'm showing you pictures from the concentration camps when the GIs came and actually relieved these concentration camps. This is what they found. They found people who were starving, who were emaciated, who were forced to have hard labor and were forced to eat very small amounts of food. And of course, what the US did, and we in Europe are still incredibly grateful to you, you actually worked out what was called the Marshall Plan. And part of the Marshall Plan really had to do with when the GIs were allowing these patients or people to come out of the concentration camps, gave them food, what happened is they caused refeeding syndrome. So a lot of us that's involved with parental nutrition are aware of what happens if you refeed somebody too quickly and in the wrong way. You give them the wrong food, what you will actually do is can cause sudden cardiac death because of shifts of potassium, for example. So what happened was the study was set up, the so-called Minnesota starvation experiment in the 1940s. And the purpose of this study was to understand not only the people in the concentration camps, but also the other people that lived in famine in the US, how to refeed Europe. So it was about doing a scientific experiment to get a scientific basis to refeed Europe. What nobody understood is once the famine came to an end after the Second World War, what food do we have to give people to actually allow them to become healthy again in the short and long term? So what they did is they took healthy volunteers. These were conscientious objectors that wanted to contribute to the war effort, and what they allowed them to do is to lock them up in a big football stadium and starve them over a 24-week period, and then allow different refeeding treatments to come into play. Now, as an internal medicine doctor, I sort of will joke with George and say to him that I can make anybody lose any amount of weight much faster than he can by doing exactly that. Locking somebody up in a room, giving them 2 liters of milk a day with a double dose of multivitamins, I can make anybody lose a quarter or a third of their body weight. The problem is, when they come out of that situation, they're like starving Marvin. They're incredibly hungry, and they regain their weight very quickly. What George and Christine is doing, and they are actually able to allow people to lose weight and maintain their weight loss. That is really the magic. So what we learned from the Minnesota Men study, by studying these individuals very carefully, the first thing is that, yes, we can make people lose weight by starving them. It is not difficult, right? And here you can see what happened to these individuals losing 24–30% of their body weight. What we discovered while that study was ongoing was that the first thing that happens when you lose that much weight is you turn down your energy expenditure. So what you can see over here is what we refer to as non-exercise activity thermogenesis. It's really instructive to listen to some of the voices that has been recorded of these participants in the study, how they explained that they became lethargic, that they became depressed, that they just did not want to move, and the observations were made that they stopped twitching. They stopped moving. And you will know some of your friends that have body mass indexes of 21 but eat like horses. What happens to them is they're constantly moving, they're constantly twitching. And what we see when we actually put people on a diet approach, what happens then is they stop moving. This non-exercise activity thermogenesis is turned down in this regard. We also see that basal metabolic rate, so the amount of oxygen that you consume and carbon dioxide that you produce, reduces dramatically. So now we understand why, even though I would starve somebody, I cannot make them disappear. Right? At some point, the weight stabilizes, even if that's a 25% or 30% body weight, because at that point, the energy expenditure is turned down so that the body can maintain and not become into a critical situation. So here's the old graphs. It's all drawn by hand, as you can see. So what we will see is this is the reduction in fat mass. And what we also see here in red is the reduction in fat-free mass. So that's not only muscle, that's also bone. And this is the 24-hour period where the patients were being starved. And here we have a restricted food that was being given, and here we have an ad libitum food intake. So what you will notice is that the fat mass recovers first. And therefore, the fat mass continues to recover, and then the fat-free mass takes a much longer period to recover. So this was one of the first experiments to show us what is happening today in our patients who go to the Biggest Loser program or go on a starvation program. What happens is they can maintain it for a period of time, but when they start eating again, what will happen is they will actually gain fat mass first. So if you want to fatten somebody up, if you want to increase somebody's fat mass, a really sensible approach is to starve them. Put them on a starvation diet, and what will happen is they will have a higher fat percentage after your program than they would actually have had before they started. And this is typically one of the gentlemen that you can see who lost 24.5% of his weight, and this is him after he is refed. But now I'm going to return to that graph again and point out which I think is one of the most interesting observations. Here, just to remind you, this is the fat mass, this is the fat mass increasing, here's the fat-free mass coming back to where they started. But look at this graph. This shows hyperphagia. It shows that the patients became hungry and continued to overeat up to that point where their fat-free mass, their muscle mass, came back to normal. And once their muscle mass returned to normal, what you can see is their fat mass was obviously very elevated at this point, meaning they were heavier after the intervention than they started. But at that point, the hyperphagia subsided and they came back to a normal food intake. And that is what plays out year after year after year when we see programs such as The Biggest Loser, etc. So we see these patients becoming hungry. And now I'm going to sort of, challenge you again in the audience and say that I will give each one of you $1 million if you can hold your breath for 10 minutes. Okay? And you are smart enough to hold your breath, and you would be motivated enough by that $1 million. But at some point, at a minute or a minute and a half, you're going to start taking another breath. Because at that point, your medulla oblongata overrules your greed centers in your cortical areas. Right? So that is the problem that we have when symptoms such as hunger and satiety is driven by the subcortical areas of the brain and not the cortical areas. So that brings me to this question that we ask our medical students, what are these pathognomonic symptoms of obesity? Because what we have done in obesity medicine, we have been incredibly focused on the signs of obesity, which is excess adipose tissue. We thought our job was to treat the signs of this disease. But most good doctors all across the world are not that focused on the signs of the disease. We alleviate symptoms. That's the first thing we do, is we alleviate symptoms and we prevent complications. But when we ask our medical students, what are these pathognomonic symptoms of obesity, what they very often come up with are the complications of diabetes, or depression, or sore knees, etc. These are all complications of obesity. So when we look at this painting that actually hangs today in Madrid in the Prado, painted in 1680, this is a young girl that was 6 years old that weighed 70 kilograms. So what happened was she was caught in the periphery in Spain and brought to the palace. And it's actually, she was painted with clothes, without clothes, and actually held her. And whenever dignitaries came out, they would roll her out and people would look at her and think, this is really grotesque, what an interesting observation this is. So it teaches us two things. One, that the stigma of obesity is not new. As a society, we have been looking at people who have morbid obesity for quite some time and wondering why they are so different. But really the reason why I'm putting this up is to say that if this young lady walks into your office today with her mother is going to ask you the following question. She's going to say, please, doctor, help me, because my child is hungry all the time. And when my child eats, my child does not become full. I have to give my child a large amount of energy before my child feels full. Now, many of you will have children or have nephews and nieces, and you try in a civilized world to starve a child that is hungry and deprive that child of food. You see how well you feel after you've done that. And that is really the challenge, because these are the two symptoms, excess hunger and reduction in satiety. Now suddenly the penny starts dropping, because now we know what we need to do. If we want to treat people with good diet approaches, good exercise approaches, medication or surgery, what we first have to do is alleviate those symptoms, because then the behaviors become natural. So we have to ask ourselves, if those are the two symptoms, where are the neurons in the brain that code for hunger and satiety? And of course, if we do a gene-wide association studies, you can see that 80% of the genes point to the central nervous system. So at least we know which organ we are treating, because for a very long time, we did not know what organ we should treat in the fight against obesity. And if we look inside the brain, we can see it's the subcortical areas. I'm highlighting the hypothalamus here, but I could also show you the area postrema. I'm showing you the subcortical areas of the brain. And what we have done for the last 20, 30, 40 years is we've engaged in the cortical areas of the brain. We've been trying to teach people to be better citizens, trying to give them the information, scare them and say, do you not know that obesity is going to kill you? You know, do you not know that you have to just be a better person? In actual fact, there isn't the connections between the cortical areas and the subcortical areas of the brain to make people feel less hungry and more full. Now that we have better treatments, we are able to do that. So whether or not we use diet, medication, or surgery, if we do not interact with the arcuate nucleus, for example, and the hypothalamus, and we do not increase satiety and reduce hunger, we have no chance of changing the behaviors. So certainly in my clinical practice, if I start a diet approach and the patient comes back to me and says, doctor, this is so easy. For the first time in my life, you know, I'm not feeling hungry, I'm feeling full, you know, it's just really natural. I know my approach is working. If I start the medication and the patient comes back and say, you know, I'm really trying hard, I'm super motivated, I'm writing down everything I'm doing, you know, I'm really trying my best. At that point, I worry that my treatment isn't working. Because if my treatment doesn't make the behaviors natural, it's not going to be likely to be sustainable in the long term for the majority of people. So it pains me to say this, but as an internal medicine doctor, you know, I sort of joke with my surgical colleagues like yourself, and I say, you know, the surgeons found the solution without understanding the problem. So now what we have to do is we have to back engineer it, because what surgery is really fascinating about is not the weight loss. I've shown you that I can get the same amount of weight loss. What surgery is really magical almost is about the weight loss maintenance. So here I'm showing you 20-year data from the Swedish obese subject study, where I'm showing you banding patients that are maintaining weight loss. I'm showing you bypass patients that are maintaining weight loss. And understanding why that is really the crux of what the research we are doing and many others like us. So it does not matter which operation you use. There's different advantages and disadvantages to these operations. But the big myth that has been generated by these operations is that when we designed them, we thought what we were doing in good faith. It wasn't a bad thought at the time, but we thought that what we were doing is we were restricting the stomach and we were causing maybe calorie malabsorptions, you know, when it comes to operations such as the bypass, etc. Now, with the science that we have today, we can say, you know what, despite that was our intentions, and those were good intentions, we were wrong. Right? So the next time that somebody tells you this works through restriction and malabsorption, you know, ask them to produce the evidence. Ask them to show you what is the scientific evidence to support that. One of my good friends and colleagues, Lee Kaplan from the Mass General, he always refers to restriction as the tooth fairy and malabsorption as Santa Claus. And at all points, and all of us believed in the tooth fairy and Santa Claus at some point, but then we grew up. And then we actually looked at the evidence, and now we actually hold different views. And it's time for us to do that. Because what these operations, the way they are working is through physiology. So here we're showing you the gastric band, and really we now understand that it's the pressure on the vagus nerve and how the vagus interacts with the nucleus tractus solitarius in the hindbrain and how that projects forward into the hypothalamus that allows us to get these changes in symptoms. So here I'm showing you a randomized controlled trial done in Melbourne, Australia, of the same patients that either had the band inflated or deflated in a double-blind manner. And in the white blocks here, I'm showing you when the band is optimally inflated, and in the black is the same people where the band was deflated in a randomized way. In the gray are those patients who did not have an operation. And what we are measuring before breakfast is how hungry people are. And what you will see when the band is optimally inflated, the amount of hunger is substantially less than in the same person when the band is deflated. So what this band is doing, when it's before somebody has had any food, it is reducing the symptom of hunger. When somebody has a meal, what you can see when the band is optimally inflated, it makes people feel more full in comparison to the same people who had the band deflated. So what we are seeing here is that the band does not restrict the stomach. I admit that many of my patients with gastric bands have a complication of the band where the band may be too tight and does cause the complication of restriction, and we are trying for that not to happen. But what we want to hear from our patients is that the patients come back with this very typical story after gastric banding where they say, I'm just not hungry. Is it okay for me only to eat once a day? And we sort of, were in our academic ivory towers, and we said, we have to put our money where our mouths were. So if you are only hungry once a day, then only eat once a day. If you feel hungry 5 times a day, eat 5 times a day. And what we are seeing is that there is a substantial number of patients in our hands, maybe even as much as 1 in 10 or 1 in 20, where we put a really good band in, where we have a really good result from a surgical point of view, but where the patient does not have a change in symptoms, where the patient comes back and says, I do not feel less hungry. And that's incredibly frustrating. And typically in the old days, what we used to do is make the band tighter and tighter and tighter until they couldn't swallow their own spit. And that wasn't very helpful to them or to us. So now we recognize, and it's easy for me as an internal medicine doctor, because a bunch of my drugs don't work. Right? So if a bunch of my drugs don't work, I don't feel like I'm personally failed or that the pharmaceutical industry has failed. It's just that that drug didn't work for that person. Let's move on. And I think that is the thinking now, that we don't want to get stuck in one thing where it's not working. But equally so, we do not want to shoot it down when it does work for many people and have this really incredible changes in the symptoms. I'm also showing you the gastric bypass here because many of you may have heard that the bypass works through restriction and malabsorption. And when you put high-pressure manometry, as my colleagues did in Gothenburg, they showed that the pressures in the esophagus was normal. The pressures in the pouch was in fact low, and the high-pressure system occurred in the proximal part of the small bowel, in this called the alimentary limb or the rulum. So it is not causing restriction at the level of the pouch, and therefore when we are going to try to redo the operations or having revisional surgery, sometimes we try to make the pouch smaller and smaller and smaller without having any benefit, but just clocking up surgical complications and surgical risk. When we measure in a prospective study how patients react after these operations, I'm showing you gastric bypass data, but the same is true for banding, you see that before surgery, people feel hungry, and what happens at 1, 3, and 6 months, the hunger is reduced. If we actually look at what happens to satiety, we see satiety is increased. Why is that? So first of all, there's lots of different mechanisms at play, and it's super fascinating, and it keeps me in a day job, and that's what I love doing, is trying to work out these mechanisms. But what we are understanding is where we started to focus on mechanism is we should really be thinking about regulation. So these mechanisms play a role, and I'm showing you gut hormone changes such as peptide YY or glucagon-like peptide 1 or oxyntomodulin, but really, what we want to be doing is we want to understand that there's a way that the gut talks to the brain, and that communication is happening in exactly the right place where the symptoms are generated. So, for example, giving a hormone, injecting this hormone as we have done, we actually make people feel less hungry and more full. But what we see after some of these operations, such as bypass and sleeve, we see this increase in this hormone and its association with a reduction in hunger and increase in fullness. But it's when we measured the brain using functional MRI that it became clear to us that the areas of the brain that were being affected after these operations were in fact those areas that are involved with generating the symptoms of hunger and satiety, and those subcortical areas that we do not have control over through thinking. And in fact, what was happening is the reward centers were being down-regulated. And that makes a lot of sense because now suddenly our patients are coming to clinic and saying, for the first time in my life, I can walk past the cupboard. I'm not obsessed with food anymore. I'm not looking inside the cupboard anymore. In fact, now I've got 30% more brain space because I can think about all these different things in my life. I'm not thinking about food all the time. The challenge for us is that obesity is not one disease, but also the treatments don't give a uniform response. This is a perfectly Gaussian distribution. Whether or not we use gastric bypass or sleeve gastrectomy, we see this perfect normal distribution. Now, one of the problems that we've had, and certainly that's another myth that is driven by the Biggest Loser idea, is that if you are the person that loses the most weight, people clap their hands. They congratulate you because somehow you are a better person. You are morally superior, and that is why you are able to lose so much more weight than the other people that participated in the same diet program or the same TV show. Now, when we speak with people, our patients, but also when we speak to our colleagues, many people within the field of obesity now understand that obesity is just another chronic disease. And therefore, we should have chronic disease models, how we treat these people. But if you treat a patient with a good ACE inhibitor for their hypertension, and they do not respond to that ACE inhibitor, you do not blame the patient for being a bad person. You just change your treatment to a calcium antagonist or to another one of your multiple treatments that you actually have. The problem is that when somebody comes back after they've had an operation, even such as a bypass or a sleeve, and they only lose 5% of their weight, or 10% of their weight even, the usual response in clinic is, what are you thinking? You know, you even had an operation, and even with an operation, you couldn't eat less and move more. You must be a super bad person. Now, that is very challenging for the surgical community, because when you have done a really good operation and the patient comes back and the patient did not have a good response, your first default option is to go to say, there's something wrong with me, or there's something wrong with my operation. In fact, again, as an internal medicine doctor, I can reassure you that you have done a perfectly good operation, and what we are dealing with is just a very challenging chronic disease. So if the operation does not work, it's not because you've done something bad, it's not because the patient has done something bad. Just at that point, our treatment is not optimal for the patient. And therefore, even the patients that do not have a good response, they are the ones that feel the worst about themselves because they think they are the ultimate failures. You know, even when they had an operation, they still could not have a response. You know, and that's not what we do in the civilized world. We do not blame our patients. And what we say to our patients is that patients don't fail treatments, treatments fail patients. And if a treatment fails a patient, then let's move on. Let's try to find another solution. So what we've been able to do is with pharmacotherapy, replicate exactly the same thing. So here's our paper, you know, with liraglutide, which is a GLP-1 analog. And when we randomized patients, 3,500 patients between liraglutide or placebo, everybody had diet and exercise, you can see that 8% of patients that had diet, exercise, and liraglutide gained weight. Right? If we actually look at how many people lost 5%, 10%, or 15% of their weight, you can see that 14% of people lost 15% of their weight. Now, when we went back to this trial and we looked at all the psychological questionnaires that we did before, we looked at all the biomarkers, we could not pick the people apart before the treatment started. I could not differentiate this group who lost 15% of their weight from that group who gained 8%. It is not the smart people that lose a lot of weight or the people that listen to me and do what I say that actually lose weight. It is biology. Once you work that out, then suddenly treating obesity becomes really interesting, because what we are doing is we're trying to find a biological treatment that's going to help people. The tools of the future in fact, is incredibly bright, because we will get all these tools that's going to come out. And what we are really understanding now is how are we going to use these new pharmaceutical tools, these new nutritional tools, together with surgery. It's not going to be surgery against medicine. It's going to be surgery with medicine that's going to drive the future. So I'm going to summarize and suggest to you that there's a body fat set point. Your weight, your body wants you to be a certain weight. And if you live in a bad environment, for example, where you have poor diet, where you don't sleep enough, where you're exposed to a lot of stress, or even we give you medication that drives your weight up, what you will see is you can have a rising set point. And that happens in many people, not all, but it is a regulated system. So what we want to do is we want to give a treatment that allows the body to think it is too heavy. Because if you can put the hypothalamus under the impression that it is too heavy, what it will do is it will naturally behave and come down to that new set point. Now, we can do that, for example, with a lifestyle approach, not a calorie restriction approach. This is a lifestyle approach where we can change the diet, we can change activity, for example, prevent muscle mass loss. We can reduce stress, we can change medication, for example, that will drive this process up. If we do that, on average, we can get about 5% weight loss that is sustainable for 10 years. Okay? Now, some people will lose more, some people will lose less. But if you respond to this treatment, it certainly is a treatment that has very low risks. But the benefits depend on how well you respond, not on how smart you are. We can also use medication. And as I said before, we have a lot of new tools coming into play, and that's going to revolutionize it. And if you even think, what we did in the 1960s for hypertension. In the 1960s for hypertension, we had very crude diuretics or crude centrally acting agents. And we called it essential hypertension because we did not know what the cause for the hypertension was. It's only later that we understood the renin-aldosterone system, and now we have really good treatments that actually interact with the renin-aldosterone system. And today, nobody comes into this hospital and dies with malignant hypertension. In the 1960s, people died with malignant hypertension because we did not know how to treat it. Now, we are just in that same place at the moment with obesity, and thinking how we can understand the system and understanding how the subcortical areas of the brain works has really allowed us to develop these new tools. But one of the important reasons why we understand how the hypothalamic system works, or even the subcortical areas of the brain, is because of surgery. Bariatric surgery has shown us that it's not only possible to lose weight, but it's possible to maintain weight loss. Moreover, it is showing us why it is possible, because we are alleviating these symptoms of hunger and excess or lack of satiety. And now what we have to do is work out how can we predict which patients will respond to what treatment, because we're not there yet, but we will be. We will be very soon in the future. So if you think of somebody that is lean, the more food they will eat, the more satiety they will have. If this curve is shifted to the right, we call them a person with obesity. And what happens is they just need to eat more calories to allow them to feel satisfied. So what we want to do with our treatments is shift this to the left to allow them to eat fewer calories and yet achieve satiety in the long term. We can do that with our interventions, for example, taking somebody with an elevated body fat set point and bringing them down to this new controlled, regulated system. Now, one of the challenges that we have when we do this is if you actually do an operation at this point and the patient's hypothalamus becomes under the impression that it is too heavy, the only levers that the hypothalamus can pull is making you feel less hungry and more satisfied. And that's what it does really in this period of time, and that's a sort of a honeymoon period. Patients come back and it's the most incredible feeling that they've had. They've really been released, from this chronic disease. But when they come back to the set point, when they get to this new set point, be that 15% lower, 20% or 25% lower, what typically happens at this point is the patients come back and say, "Doctor, the treatment's not working anymore because now I'm hungry, and when I eat, I'm not as satisfied." And that's our next challenge, because what we are now starting to understand because of the regulation of body weight is this is a normal change in symptoms. Because when you come to this point, you become normal again. So at this point, you have normal hunger, normal satiety. Over here, you develop normal hunger and normal satiety. So the really critical point is not to say to the patient at this point is, look, this treatment isn't working, let's stop that. Because if we stop it at that point, we see exactly the same graphs that happened in the Minnesota starvation study. Patients will suddenly regain their weight. They will regain fat first, muscle less, and they will become hyperphagic in that process. So the treatments, even surgery that achieves 15, 20, 25% weight loss in the long term, will allow people to become normal. They will not make them thin, and they will not make them happy. What we see what surgery does is it makes people more functional and it makes them healthy. And that's a challenge for us because we have to change the narrative. If we think this is a chronic disease and we understand that this is a chronic disease of the subcortical areas of the brain, we have to be honest with our patients. And we have to say to our patients that what we are able to do is change that set point. We are not sure at what level we will end up with. It is not the smart people that will do better than the people that don't listen. And if you end up losing a large amount of weight, it is not because you're morally superior. Right? So do not congratulate yourself. And if you don't lose weight, don't berate yourself. It is just a chronic disease that we need to use different tools with as we go along. So please allow me to thank the team at home that's doing all the hard work, especially Professor Helen Heenan, our bariatric surgeon, my colleague Neil Doherty, that's together with me leading the team, also our international collaborators. And I'll end with this, that you know, when I sat in clinic, I would take my notes and I would say to the patients, look, you know, obesity is a disease, it's a chronic disease, we treat it like a disease, you know, and we now understand the science has changed, and, you know, I understand that this disease is not your fault, right? And at that point, when I look up for my notes, I would see grown men crying. And they would say, you know, since the age of 6 years old, I've been blamed for this. You're the first person that actually tells me this is not my fault. And because you've said that, you have empowered me. You have given me agency. Because now I know I need to do something about it, which is beyond just being a better person. I now need to seek help, and I now need to actually get help. And I understand that even if it's not my fault, it is my responsibility. And that changes the patient relationship and the doctor-patient relationship dramatically, because what we also teach our medical students is it is very difficult for good doctors to sit in an office and actually open up the conversation with the patient who have obesity. So what we teach the medical students is the first thing you say is, may I have permission to talk about your weight? The second thing you say is, we understand this is a chronic disease, that's not your fault. And the third thing you say is, we have some specialists in the hospital that can help you. Would you like me to refer you? By doing those three simple steps, what you're doing is you're giving your patient the best chance of actually having a treatment, and that could be a diet treatment, a medication, or a surgical treatment, but you're giving them the best chance to actually get control of this chronic disease and for us to help them in the long term. Thank you very much.
Well, Carl, thank you very much. That's been a wonderful, enlightening talk. I really appreciate it because it's reframing the issue and it's reframing how we can treat and help our patients, because I think you and myself, we're actually a minority. There's still vast numbers of individuals, not only in the public or insurance arena, but also in the medical field or surgical field, that still blame the patient. And how do we spread this news? How do we educate to allow patients to consider treatment, because they still consider surgery or even any medications as drastic. They don't see their situation as drastic.
So I think that's a very important question, and I think we've done ourselves and our patients a disservice with some of the public health messages that we've put out there. So the public health message is eat less, move more. And I think that's a perfectly appropriate message for people who are normal weight. If you are normal weight, what you should do to prevent you developing the disease of obesity is to eat a little bit less and move a little bit more. But we need to change the public health message for those people who already have the disease. For those people that have the disease, the public health message should be seek help. Now, that does not have to be a diet or a medication or a surgical operation. It should just be a conversation where somebody understands that this is a chronic disease. And we do that all the time. We do that all the time with hypertension. We do that all the time with dyslipidemia. So if somebody has dyslipidemia, it does not mean I'm going to use LDL apheresis on them just because they've got a total cholesterol of 200. You know, it means that I'm going to make an assessment about what is the best treatment, and I'm going to talk to the patient and understand what do they want. And I think that is important, that we don't just have one treatment that fits all. We need to have all the treatments on the table and allow patients to move between these treatments, you know, that suits them, but also where we as the medical profession can give them input, because how much weight you need to lose depends on what's wrong with you. If you've got diabetes, we can reverse a diabetes, or at least reverse the complications of diabetes, put type 2 diabetes into remission if we get 15–20% weight loss in the long term. We now even see that we can do the same with NASH. We can reverse fibrosis when it comes to NASH if we can get 15–20% weight loss in the long term. Now, that's something that even at medical school we didn't think was possible. So that's changing the world the way we see it. So the amount of weight loss changes the message, but overall, I think we need to change the public health message.
I'd like to entertain any questions for Dr. le Roux. And I have one more question, actually, and that is, there's always a question of, well, we didn't have obesity. How can you call it a disease? Or is it genetic? I mean, there is obviously a population history where obesity really didn't exist 100 years ago, and now the majority of human beings are either overweight or obese, and being lean is actually a minority in our patient population. Right. So how does one explain that?
So I live in Ireland, you know, it's a beautiful country. But you don't have to go back very far in history, you know, even only into the 1950s, and you will hear from many of the people who lived through that decade that there was a lot of children in their class that went to bed hungry at night. You know, even in this great country, if you go south, you know, and you look at the 1950s, there was a lot of people that actually went to bed hungry at night. So today, we've never lived in an environment where food has been this cheap. And of course, what we do is that those people who are at the lower socioeconomic levels, they are exposed to food that have the highest fat content or highest sugar content. So there's no doubt that if you make food freely available, as cheap as it is today, and you load it, and you then are able to unmask this epidemic of obesity, which has always been there, but it's been suppressed because people were effectively starving because of economic reasons. Now, what we are seeing is that it's flipped the other way. So now you will see, you know, on one page of the newspaper, it will say, everybody by the year 2030 is going to have obesity, and, you know, children are going to die before their parents. And then on the next page, you see, you know, we can't afford the pension crisis because we're all going to live until we're 120. And, you know, how are we going to afford this? So there are mixed messages, but also not everybody in society can become obese because they are regulated in that way. And we are looking after a population that's called constitutional thinness, which is people who are typically have body mass indexes of 17 and want to gain weight. So if they're female, they menstruate like clockwork, but they actually want to gain weight, and they're constantly being accused of having an eating disorder. So understanding that regulation and how tightly their body weights are regulated is exactly the same as somebody that has a higher body mass index. So it's a challenging question. You know, there's no doubt that the environment has played a very important role, but if anything, it's unmasked a disease that's always been there.
Mm-hmm. Yes, Dr. Packler.
Carl, so, you know, like you said, in the old days, the rich were fat and the poor were thin.
Right.
You had a lot more access to dietitians, et cetera, you know, workouts, and the poor are now being exposed to junk food.
Right.
So, you know, one of the things that's happened here is that in city population, we have now gone up to 1,200 bariatric procedures. And we could even go even further. That's just a reflection of the poor or indigent population. That's the first thing. The other thing, I'm glad you mentioned the issue of the exercise. I had a rude awakening, running a 5K at a 9-minute mile, realizing it's only consumed 4 calories.
Right.
So that's not going to knock off your weight.
No, no, absolutely. And, so what we need to understand that this is a complex issue, and I come back to the example of hypertension. We understand that if we can reduce the salt content in people's food, we're also going to make an important difference. And we have the DASH diet randomized controlled trials that show that. But if you only have a diet approach, the treatment of hypertension is going to be really challenging. So what we're saying is that, advocating for surgery or advocating for medication or for diet approaches does not negate the importance of the public health message, where we just have to have better quality food. Because if we eat better quality food, we are able to generate the signal from the gut to the brain by using that.
Right. Again, a key, for example, just a band. If the brain isn't readjusted, I know 50 people at least that outdo the band.
Yeah.
They'll have malted, they'll have chocolate, they'll have anything that goes down there, and within a short period of time, even though they have the band, can't make it any tighter than complete obstruction.
Right.
They will gain back all the weight.
And those patients are super interesting because what happens is that they don't have any of these signals of reduction in hunger and increasing in fullness. And in the old days, we were not prepared to say that this treatment isn't working for you. And now when we actually look at all our treatments, be that diet, medication, or surgical approaches, and Flavio, who's one of the research fellows in the room, is actually doing a really nice paper at the moment that shows that we can predict how much weight somebody is going to lose in 2 or 3 years by the amount of weight that they lose in the first 3 months. So if you have these profound changes in symptoms, then you're going to continue to do well. But if we don't do well in the first 3 to 6 months, maybe it is time for us to say, this has not worked well enough, and let's either add another treatment, and I think that's where the opportunity is of adding medication or diet approach with the band, and also to say that maybe we don't have to have 25% weight loss in everybody with a gastric band. Let's get 10% weight loss with the band, and then amplify it by maybe adding a diet or medication to get 15% weight loss in the long term. But there's no point in punishing people if a treatment isn't working.
One more thing is, how do you predict, and you've touched upon this, is there any predictive model on who's going to be a responder and who's not going to be a responder? Is there an algorithm? We have a cancer algorithm. We take a biopsy. You're receptor positive, you're receptor negative, and therefore your treatment is X, Y, and Z. When do you think that we will be in a situation where we can define the phenotype of the obese individual and then give them a prescribed individualized treatment?
We're not there yet, and I think we need to learn from our cancer colleagues, because what they have done is they've revolutionized their treatments by better diagnostics. And even if we think about breast cancer today, 10, 20 years ago, we thought breast cancer was one disease. Now we understand that breast cancer is 9 different diseases that just happens to be in the breast. And depending if you're HER2 positive or triple negative, we give you different treatments. Now, we are not there yet with our obesity treatment. But again, I did an oncology job as part of my training, and I remember that people came through with breast cancer, and we gave them the best regime that would work for most. But if it did not work, what we did is we stopped and we switched. Now, I think that is what we have to do with obesity care, that if we start a treatment and it's not working, and we can tell, as I said, within 3 months, it's time to change. And it's not a bad thing to change. It is a very reasonable approach, and we've done that in medicine quite a bit. Of course, we will become smarter. Of course, we will have the ability to predict, but that's not immediately around the corner.
Well, I'd like to thank Dr. Carel le Roux for coming and sharing your knowledge and experience with us this morning. Have a great day.
Thank you. Thank you very much.